Good afternoon, everybody. We're going to start the Telegram rounds today. I go to present a case. Let's go to start. I hope the case is very interesting because it's not unusual case, but sometimes the treatment may be different that I do. Okay, let's go to present. Okay, go. It's a 24-year-old man. He has a left chest stab wound. This patient's 24-year-old man at 22 p.m. He was going to start his initial assessment was in a basic healthcare unit. During the fight, the patient was a stab wound in the left chest. He reported local pain blended from the wound. Doesn't mention node spinae here. And 22 p.m. patient has a respiratory rate was 24, saturation oxygen was 98%, centered trachea without tubular spasm. They put a catheter of 2 liters per minute. Breathing, murmur vesicular present bilaterally. Systolic pressure 120 by 92 millimeters of mercury. Cardiac rate is 91 BPM, and saline was placed for venous access. Glasgow coma score is 15, pupil isochoric and photoreagent. At exposure, can see a 4 centimeters wound in the 7th intercostal space on the left anterior axillary line. I go to ask the people what they do. You have a patient who was stable with a stab wound in the chest, blending in the sea, but he has murmural respiratory sounds present bilaterally, and he was stable. What to do in this patient at this moment?
Dr. Frisbee, Atlanta.
Do you fast? Let's see where that the tip of that knife wound is. Most probably at the seventh intercostal space. He might have caught the cardiac muscle, but at this point nobody knows. He's 24. He's got plenty of reserve. So the first thing I would do would be a pericardial and chest fast, and also an upper abdominal fast, just to make sure he didn't cross the diaphragm. That's the first thing I would do. And then, of course, a chest x-ray.
Thank you, Dr. Frisbee. Dr. Antrak, like that?
Yes, I think that's spot on. 7th interspace laterally. It's not in the box, but you don't know the kind of knife. It's 4 centimeters, so it sounds like either could have been a wide knife, meaning if it's wide, it's also long. And then 7th interspace is right, it's below the dome of the diaphragm. So depending on whether he stabbed up or down, it could have easily gone into the left upper quadrant. You certainly need to do an EFAST, be confident of the results, and then chest x-ray. He's totally stable, so if there's any doubt about what happened, you could do a CT, but I wouldn't go right to that first. And then I would IVs and all the other things you would do for any trauma patient.
Thank you, Dr. Antrak. Dr. Fraga?
Good afternoon. Yes, I agree. It's very important to have a ultrasound fast, EFAST, looking on the chest too, and a chest X-ray. But probably in this basic health unit, they don't have this research, correct, Dr. Collet? They don't have there?
Yes, they don't have ultrasound. They have X-ray, but they don't have ultrasound.
So I think as ambulance is very important to transfer these patients to a trauma center and transfer as soon as possible because the patient is stable at this moment. So the patient needs to go to a hospital, a trauma center to do the investigation. Just já have a saline to receive fluids. So just try to transfer the patients.
Thank you, Dr. Fraga. Dr. Kasim, your comments, please.
So what I do in cases like this, I categorize my patients, especially in stab wound, and it's entirely different from the gunshot wound, whether they are arresting or stable or unstable. And it looks like this patient is stable, so he this patient goes into the category where I have time as my luxury, a little bit at least. So don't forget, we rush to do things without examining the patient. Sometimes it is worth examining the patient, and you look at the neck vein to see if he has any jugular venous pressure distension, and look at the serial blood pressure measurement to see if he's got narrowed pulse pressure, and listen to the heart sound to see if he's got any of the distant heart sounds. Those are the stuff that we were taught in the medical school. Sometimes we forget them and we go straight to investigation. Yes, investigation is very, very important. In a case like this, if you have an ultrasound, it is very easy to put the ultrasound on the pericardium to see if he's got any pericardial effusion or if he has any signs of pneumothorax. But if you do not have any of that, then the modality of investigation would be a chest X-ray. And of course, any stab wound in the left anterior chest wall, anterior axillary line, and you will be suspicious of pericardial injury, myocardial injury, and sometimes the knife will be in a different projection, and it may even hit the thoracic aorta or esophagus. Miss everything and go into the esophagus. And we should be aware of all this. And lastly, traversing the diaphragm is a real possibility in cases like this. If obviously is a right-handed patient who stabs in the left side of the chest, and sometimes the direction of the knife is towards the abdomen, thereby making a hole in the diaphragm. So chest X-ray, and if you don't have an ultrasound, it's important. And after that, you should follow up with the insertion of a left chest tube to see if he has any hemothorax. Thank you.
Thank you, Dr. Kasim. Dr. Rahman, Boston.
Well, this patient is hemodynamically stable. You need to investigate. Chest X-ray, EFAST, because it's more sensitive to diagnose pneumothorax, looking for pericardial fluid. And if those are negative, my concern will be in the abdomen because this is a thoracoabdominal stab wound. Based on the location, I would be more concerned about the abdomen than the chest, but the chest is more serious, so you need to rule out that first. If there is air under the diaphragm visible in the chest X-ray, you can have the diagnosis there. But that's it. I will do those things. And if the patient remains stable, I might consider then doing a CT scan. Thank you.
Thank you, Dr. Rahman. Dr. Collet, we go back to you.
Yes, okay. It's very important to do because when the patient is in the primary care or basic health care, they don't have much exams. So they make an X-ray. It's a normal X-ray. So they put the patients in observation and they ask for transfer the patients to the hospital. But at 1:20 to 25 a.m., 2 hours later, the patients become restless and dyspneic. Respiratory rate was 140, saturation is 90, left chest, no respiratory sounds, blood pressure is normal, cardiac rate is 140 ppm, plasma score is 50, pupil is occurred and photoreagent. So The diagnosed suspicion was an pneumothorax. They put a chest tube was placed, drained 150 millimeters of blood and air, respiration improvement. So here is the patient, the X-ray before the chest tube was taken. Let me see what to put here. Okay. This patient was, at this moment, was transferred to the hospital. It's very important. This patient for the hospital is at 4 a.m. Respiratory rate was 15. Saturation is 98%. Tracheal center without jugular stasis. It was continued with catheter R2. Normal vesicle present. Chest tube oscillation and drain blood secretion approximately 15 millimeters of blood. Systolic pressure is 100 by 110 by 70 millimeters of mercury. Cardiac rate was 80 BPM. Saline was placed and continued to infusion. He was Glasgow Coma score, pupil isochoric, and reagent. And the patient comes for the hospital. The wound was, the chest was sutured. So you can see here the patient, the injury sutured, the chest tube, and hemoglobin is normal, leukocytes is normal, platelets is normal. And what to do at this moment with this patient? You go to exam imaging, someone may be asked for no operative treatment or go to a surgery.
Dr. Ochman, Boston.
Well, we don't know what's wrong with this patient at this time. He doesn't appear to be bleeding. The whole presentation is more suggestive that he had a tension pneumothorax that was alleviated by the chest tube. Have 500 cc's of blood there. He didn't get any fluids, apparently just only 1 liter of crystalloid, so the hematocrit might not be very sensitive. He is not tachycardic, but is borderline hypotensive, so he might be bleeding. So where can he be bleeding? He can be bleeding in the chest and is partially being drained by the chest tube. He might be bleeding in the abdomen. The source of bleeding in the chest will be the intercostal vessels, the lung, or the diaphragm, but doesn't seem to be too much because it's only 500 cc's and there is not too much visible in the chest X-ray. Could this be a pericardial tamponade? It's possible, but less likely. The patient improved with the chest tube. Pericardial tamponade, the blood pressure and the heart rate should have not improved just only with the chest tube. Can he be developing one? Yes, he can. So at this time, we need more information. And if the patient with those vitals, we are talking about 6 hours later, I would repeat the chest X-ray and the ultrasound in the trauma bay because that's really fast. But after that, probably I will obtain a CT scan, which will allow me to look at the abdomen and the chest. Thank you.
Thank you, Dr. Ochman. Dr. Kasim, Portland.
Well, now it becomes a mystery. What's happening to this patient? Although he was stable initially, he's beginning to show signs of hemodynamic instability. It doesn't look like that he's lost a lot of blood, and yet his blood pressure has dropped and he's become tachycardic. I think the tachycardia should alert us that he has occult bleeding somewhere, or he may have a viscous injury as well. So you have a chest tube in place, and then you need to repeat everything that you have done before to make sure that you get all the information documented, and you might get some new information as well. At this moment, he's not in danger of crashing, and there is no established diagnosis to take him to the operating room, and he doesn't warrant anything urgent. He may require surgery later on, but at this moment, he doesn't require to go to the operating room. So I would probably do some further investigation. And if he's being transferred to Dr. Collet's hospital, and maybe they have the investigational tools available. And if he is relatively very stable, he probably will do at least single contrast or double contrast CT scan to see if there is any obvious injury to the viscus. Thank you.
Thank you, Dr. Kasim. Dr. Fraga Campinas.
Yeah, I agree. You need to investigate this injury. I think it's very important the pericardial ultrasound to rule out there is no cardiac injury. The stab wound. Can you come back with the slide, Dr. Collet, just to show for the students here? It's very close to. It's in the Zider area. It's not in the Murdoch area, but this stab wound is in the Zider area. So it's mandatory to investigate the hurt if there's no pericardial effusion. So the first exam at the emergency department, you can have another chest X-ray, but it's a thoracoabdominal injury. You need to investigate the diaphragm. You can have a diaphragm injury or including abdominal injury in this area. So the patient is stable. I think the CT is a good option, but in my opinion, this patient has indication for thoracoscopy, a vet to look for the diaphragm if it's no injury in the diaphragm. So it's very important. Exclude cardiac injury, diaphragm injury, but totally stable. You can have a CT before go to the OR.
Thank you, Dr. Fraga. Dr. Antrak, like that?
Yeah, so all very good comments. So the patient is stable. He's not tachycardic. His blood pressure is fine. And presumably he's awake, he's extubated. And I agree, I would do a thorough EFAST at this point, which hasn't been done yet. And you can he's nice and thin. You can really get a good look at the heart and pericardium, and then the peritoneal cavity. And if he's awake, if he remains stable clinically, hematocrit stable, and his abdomen is benign, it's perfectly fine to watch him. But you know, I think most people would probably then go to a CT scan, and especially since this case is being presented here, if he didn't have something unusual, it's probably going to be a diaphragmatic injury that was repaired by VATS, you know, and it'd be reasonable to do a CT to see if you can see evidence of a diaphragmatic injury, and then you go ahead and take care of it. I think that's probably something like that happened here. And I think most people would probably go to a CT scan, because if anything happens afterwards, you get criticized for not doing it. And I would probably do that even if you were stable. One point about the patients being at the urgent care center initially, and it's a very good point. If you know that the people there can put in a chest tube, and there's if there's any bit of distance between the urgent care center and the ER, it's probably a good idea to have the doctor there put in a chest tube en route, unless you're sure the paramedics will be able to decompress the chest if the patient destabilizes in the back of the ambulance.
Thank you, Dr. Antrak. Dr. Frisby, Atlanta.
I appreciate all the comments. You know, if you're, I understand about the diaphragm and et cetera. CAT scan will give you about 50 or 60% sensitivity. But if you're going to do a CT scan, don't send him, take him with you. Go with him. This is one of those patients that may indeed be just as strong as an ox until he gets there and crash right on you in the table. So if it was me, that's what I would do. I'd get a contrast CT, but I would be right there with him. Other than that, I think all the comments are appropriate. Thanks.
Thank you, Dr. Frisbee. Any other one? Any doctor has any other comment? I see Dr. Pereira, but I'm not sure if you would be able to see. Dr. Pereira, would you like to make a comment?
Just listening today. Thank you.
Doctor. Yes, Dr. Kasim, go ahead.
Would you suture that wound? Is that appropriate?
For just injuries, it's not a gunshot wound. It has a stab wound. Sometimes you can debride it and suture. There's no problem. But if it's a gunshot wound, I don't suture. But a stab wound, I can suture. Okay.
Thank you.
We go back to you, Dr. Collet.
Okay, let's go to show something that's very interesting in this case because they make a CT. Here you can see the CT. You can see some hemothorax or some fluids in the pericavity. The drain is okay. There is no other injuries can see in this CT. And the CT is the chest for the pulmonary. You can see here pneumothorax and fluid here in the back of the chest. So at this moment, you can see what to do. Thoracotomy, laparotomy, thoracoscopy, laparoscopy. I have something important in this patient because this patient is asking for it. The patient says he wants to eat. He is angry, and he wants to eat. And his abdominal cavity exam, clinical exam is normal. There is no signs of peritonitis at this moment. So this patient want to eat, and the CT can see only retain hemothorax a little and retain a pneumothorax. So what to do? Thoracotomy, laparotomy, thoracoscopy, laparoscopy, or can we try to change the chest tube and see what's happened to the patient?
Dr. Fraga, Campinas.
The patient is stable. I think the best options are thoracoscopy because the patient already have the chest tube in the pleural cavity on the left. You can observe the pericardium by thoracoscopy and the diaphragm. If you find a diaphragm injury, obviously you need to do a laparoscopy because it's very difficult to suture through the thoracoscopy. You need to exclude abdominal injury if you have a diaphragm injury. So usually in our hospital, we start with thoracoscopy. But the other option is laparoscopy to look in the diaphragm, just to exclude diaphragm injury. Depends of the experience of the surgeon to choose what is the best access. Thoracotomy, laparotomy, only if the patient was not stable. But at this moment, you can do by video the procedure. Okay, thank you.
Thank you, Dr. Fraga. Dr. Ochman, Boston.
Well, you have a patient who is stable. Like probably what I'm going to say is going to shock most of the audience. I would just leave it alone for the time being because many of these small retained hemothorax and pneumothorax, they drain spontaneously, just with letting the patient move. Before doing, if I need to rule out a diaphragmatic injury, few things. One, I need to make absolutely sure, and I don't know if this was done on this patient, he has an echo or a fast that I can see the pericardium. Because when the patient is positioned on right lateral decubitus for a thoracoscopy, he can become hemodynamically unstable. So that would be the first thing to rule out. The CT scan didn't show any active extravasation, so it's no rush to do any of these things. I can wait. And to rule out a diaphragmatic injury, I agree with Dr. Fraga. The visualization through the chest is much, much easier. Through the abdomen, in this case, will be okay because it's anterior. A posterior injury, visualization through the abdomen is very difficult, while from the chest is always very easy. The location will determine what is easier to repair, laparoscopic or thoracoscopically. If it's more centrally located, they're both the same. If it's anterior, probably the abdomen is easier. If it's posterior, definitely through the chest, if you're trying to do it thoracoscopically or laparoscopically. But that will be it. There is no rush. If he might have an injury in the diaphragm, but I will wait until this declares itself. And after that, proceed with the thoracoscopy, evacuate the pneumothorax and the pneumothorax, unless something changes. But at this time, the patient appears stable, no active bleeding. I will probably wait. And I know that that's probably the wrong answer. So, but this is, because I'm sure that that option is not there. So probably something else has to be done. Thank you.
Thank you, Dr. Rahman. Dr. Kasim, your comments, please.
I was thinking about the time lag. Is it more than 6 hours or 8 hours since this injury? I think we are approaching 6 hours, right? About 6 hours or 8 hours?
Yes, more, 8 hours.
8 hours, right. So when you have prolonged time period between injury and what you're going to do, especially if a patient has significant hemothorax, don't forget, they get well adherent to tissues that you may not be able to completely clear it up with thoracoscopy. I know what Dr. Collet is going to do. He's going to do thoracoscopy because he's a master surgeon with the scopes in the chest or in the abdomen. And that's what he would do. So I need to make a determination. What am I looking for here? Am I looking to completely evacuate the clots that are formed in the chest, and at the same time get a clear visualization of the diaphragm to make sure that he has not penetrated the left leaf of the diaphragm? And I need to be confident that he did not injure any viscous below the diaphragm. I need to look at that contrast study one more time to make sure that the stomach and the transverse colon and the hepatic splenic flexure have not been violated. And having determined none of these are involved, I'm mainly looking at to rule out diaphragmatic injury and total evacuation of the accumulated blood in the left thoracic cavity. I'm old school, so I think I'll probably will make a mini thoracotomy and get the problem solved and get the patient back to the operating room. There is a mini thoracotomy incision that I was taught by a great surgeon in London many years ago, and I still use it because I'm not confident that I will be able to completely evacuate the clots that are formed and adherent to the lung and other parenchyma in the chest. But if you are very good with thoracoscopy like Dr. Collet is, that's the way to go.
Thank you, Dr. Kasim. Dr. Frisbee, Atlanta.
I'm not very competent with thoracoscopy. Let me start out by telling you that. So my thought of this is, if there is a violation of the diaphragm, I'm going to use the laparoscope just to make sure I can identify it and close it up. But you're absolutely right, Kasim. You know, the longer they wait, the more this blood clots in the chest cavity, and actually vacuum evacuating it is going to be a pretty horrible thing to try and do. You may resort to a mini thoracotomy, but I'd start out with a laparoscopy. That's all I have.
Thank you, Dr. Frisby. Dr. Antrak, Baghdad.
Yes, so in this patient, really what you have is somebody with a chest tube that's not functioning properly. And, you know, in this case, as part of the exam, I would do the EFAST and look at the pericardium and then see there wouldn't be any sliding of the pleural surfaces on the left side. And then when you look laterally, look at the spleen and the diaphragm and the left kidney, you'll be able to see the evidence of a hemothorax by looking at you'll see the spine shadow, the spine echoes extending well up above the diaphragm, meaning that there's fluid rather than air-filled lung in the chest. So you'd know that. And so non-functioning chest tube, first see if you can make it function. So milk the chest tube, use a peristalsis on the chest tube to see if you can open it up. And then if not, then go ahead, put a second tube in. And then if that didn't work, then I think it's reasonable to do thoracoscopy. And really the only difference between a thoracoscopy and a mini thoracotomy is with the former, with the thoracoscopy, you can see much better. So it's and then you can see everything and access everything so much easier. But I would proceed in that fashion. I don't think I would go straight to the operating room in this case.
Thank you, Dr. Antrak. Dr. Collet, we go back to you. We cannot hear you, Dr. Collet.
Okay. I agree with all comments. This patient was relatively stable. There is no injuries. The patients want to eat, and so we decided to. This CT was made 12 hours after the patients arrived here in the hospital. It's not the university hospital. It's the more a municipal hospital. And you therefore decide to make these patients to check the chest tube and to check the aspirate the clots in the lung and put the patients on next day, Monday morning, to the video thoracoscopy fast. So when we come into this chest, we can see here there is the patients continue stable, but you can see here, not as a fluid is not blood, it is a purulent fluid in the chest. You can see with fibrin. You can see here the chest, you can see the subclavian artery, here's the mediastinum, and here you can see the cardiac movement, the pericardium is normal, you can see some pus in the chest, fibrin. The patients continue stable, no tachycardia, no problem. So you can see here, go down to see the diaphragm and to move the lung. There is no air link in this patient. You can see. And go to see here is the diaphragm, the lung. You can problems to take this lung from the diaphragm here. I go to put more quickly. Then wash the pleural cavity, no clots. Oh, sorry. No clots. Only fibrin, purulent secretion. And here, you can see the diaphragm here.
Dr. Collet, only 12.
Okay, just a minute. Just
Just a
a
question.
minute. Okay, let me finish here. You can. Oh, sorry. I can show what's the findings here. Here, you can see the diaphragm here and a hole in the diaphragm with a peplum crumbs through. Here you can see this diaphragm, 1 centimeter diaphragm hole, and in the manipulation, you can see aeration of the aumento epiplum to the chest. So at this moment, you can see here, can see the patient here, can see the when finding the hole here. You can see here in diaphragm the hole. And so at the moment, the great question, what to do with this patient? You can go to a laparoscopy, you can go to a thorax, may go to a laparotomy in this patient. What to do? Gustavo, por favor, qual a questão? Which question? Gustavo?
Yes, the question is about this. It's so many contamination. It's only 12 hours after the injury, after the trauma,
Yes.
or the day later.
It's a 24 hours at this moment.
24 hours.
Yes.
24 hours. But it's a lot of contamination. Now we
The
understand.
patient is not, there was no signs of sepsis, no signs of peritonitis, no signs of infections. The patient is still hemodynamically stable.
Yes,
It's very important, Gustavo, to see this because missing injuries may become so frequent when you start to think about no operative management in the transitions or thoracoabdominal transition, and sometimes it's important to see this. At the moment, I want to know what to do with the patient.
May I start? May I start? This is the problem because I think there's a lot of contamination in the pleural cavity. Probably there is a stomach or a colon or a small bowel injury with peritonitis, and you have this infection in the pleural cavity. So in my opinion, your experience here, probably this patient go direct for laparotomy because you need to do a good inventory of the cavity, the abdominal cavity. If you have a large experience in laparoscopy, you can do by laparoscopy. But I don't feel comfortable with laparoscopy if you need to suture a hole in the stomach or investigate the colon. So in my hands, I go direct to laparotomy in this case.
Thank you, Dr. Fraga. Dr. Antrak?
Yeah, so in this case, I would rinse out the pleural space, suture that defect via VATS, because I think it's going to be easiest that way with that view. And then, and in fact, it's probably something I should have thought about before. If you're doing a CT scan in this case, where you can have an injury anywhere in the GI tract, the esophagus on down, in this case, I should have asked for, and what I would do, what I hope I would do is ask for oral contrast in this case, to be sure, just to rule out injury to certainly the upper GI tract, and in his case, because he's stable, I'd follow it all the way down through the colon, and if the Otherwise, the belly's benign. There's no fluid in the peritoneal cavity. If that's negative, then I think you can avoid doing a full laparotomy or even laparoscopy. And I agree, laparoscopy might be a little difficult unless you to find the pathology, unless you see signs of stool in the peritoneal cavity or bile or something, an obvious sign of a more significant injury. In which case, if you don't find the injury, then you'd have to convert to a laparotomy. But in this case, I would take care of the hole in the diaphragm, rinse out the pleural space well, have good chest drainage, and then do a very thorough oral contrast CT scan to rule out injury from the esophagus, stomach, and then on through the small bowel and into the colon if possible.
Thank you, Dr. Ontrak. Dr. Frisby, Atlanta.
Laparoscopy. You're going to have to close that diaphragm. That piece of adipose tissue didn't get there by going halfway through the diaphragm. It went the whole way. So what's on the other side, nobody knows, but you're going to either have to do a laparotomy, as Fraga suggested, or you're going to have to do a laparoscopy. Either way, there may or may not be a visceral organ involved in this. It may just be the fat. And if it is, you can extract that piece of fat into the abdominal cavity, find the hole and sew it up. So that's the only thing I would do. But I appreciate all the comments.
Thank you, Dr. Frisby. Dr. Kasim.
I started earlier on by saying I would get a double contrast study. What I should have emphasized was, one was, the vascular study, injecting that into the vascular system, plus an oral contrast. Oral contrast would be mandatory as well. Sometimes when I'm suspicious of cases like this, I also do a triple contrast, whereby introduce something through the rectum to look at the splenic flexure to make sure that the knife has not gone through the splenic flexure. Well, in this particular case, now that I have opened the chest or looked through the chest with a scope, and I beg to differ with my highly educated friend, Dr. Ontrak, that I can see much better with my eyes than the laparoscope. So I would have seen this, and then I would be suspicious. There's a hole in the diaphragm, and there might be a hole in the viscus, and the omentum is just a seal, and I would just leave it alone, wash out thoroughly, don't close the hole right now. Then I would resort to an abdominal incision, and I would track that omentum into the diaphragm, pull the omentum back, suture the diaphragmatic hole via the abdomen, because it helps me to track where the hole is by leaving as things as they are. But I would do a thorough washout of the left chest, and then I will look for a viscous injury either in the stomach or the GE junction or small bowel or maybe even the splenic fracture. Most likely, I think I would be suspicious of the stomach being injured here. The contamination that this patient has sustained in a matter of 24 hours is quite impressive. And I think there is a lot of inflammation going on here, and the patient's immune system is probably very good. It is not reacting to the inflammation that what we see and what we see on the lab. He doesn't have any fever, elevated white count, and all the other stuff. We don't have a lactate, so it doesn't help us very much. But still, I think my way of treating this would be clean out the abdomen, go into the abdomen, track the omentum, close the hole, and look for another hole somewhere in the GI tract. Thank you.
Thank you, Dr. Kasim. Dr. Ochman, Boston.
Okay, my comments will be I will be charged with heresy for the things I'm going to say now. This contaminant, there is no succus here or stool. This is only fibrin. So if I have to take a guess, the injury is in the stomach, and most likely the knot is already sealed. This is the typical inflammation that we see sometimes when we operate in a perforated ulcer that is already sealed. We see fibrin and not too much more. The patient was asymptomatic, has no fever, no white count. Yes, this in the chest is a problem. As Dr. Undrat said, I would wash this very extensively. I would probably close from the chest because it's a small hole. And this is kind of probably will get me kicked out of here, but I would just wait and see what happened. Patients with peritonitis, they have a stab wound to the bowel or colon. In 2 hours, they are begging you to take them to the operating room because they're in excruciating pain. This patient was eating or wanted to eat. So my feeling is that an exploration, what is going to show is that the omentum already sealed a very small perforation in the stomach. And the only thing that we will achieve by exploring is removing the omentum from the perforation and suturing back on. If I have any question, I will do this laparoscopically. But at that time, again, I didn't see the patient. We are just kind of like, if the patient was totally okay before I took him to the OR, I would probably wait. A few other comments. I very disappointed with my experience with oral contrast in the GI tract and CT scan. I think, in my humble opinion, the CT scan for evaluation of GI leak is very overrated, particularly the triple contrast CT, maybe the triple contrast injuries to the rectum, but nothing else. The splenic flexure is very difficult to see with oral and rectal contrast. The contrast gets very diluted by the time it gets there. So I don't find the CT scan particularly useful to find small holes in the GI tract. So that's something I would probably not do in a case like this. But that's all. But yeah, I'm sorry. That's a crazy idea not to do anything. But I had the feeling that the laparoscopy will be probably not very, the findings might be minimal. So I will wait. Thank you.
Thank you, Dr. Ochman. Dr. Collet, we go back to you.
Yes, here you can see start with a laparoscopy in this patient. You can see the diaphragm injuries, the peplum go up, and I go to show. You can see only a small contamination in this area or near the stomach. Here you can see the hole, the diaphragm hole. You can see some fibrin near the spleen. Is the hole, diaphragm hole is a 1 centimeter hole, and we go to see here. Go to explore this area, go to washing and see here. You can see here. You can see a stomach, anterior portion of the stomach, hole, injury here. You can see. This is the great problem for this patient. It's a small hole in the stomach and is his anterior wall. In these situations here, unfortunately, I have some different tools. I can suture using make to tie the hole. And, in this situation here, I stapled the hole. You can see here. It's very easy to do in this situation, in this special wound. And the diaphragm was sutured. Use one tie. Oi. Tá. Suture the hole. Only one stitch. And washing and review now. Washing and review all the peritoneal cavity by the laparoscopy. There is no more injury here and no contaminations other sides of the abdominal cavity. Only on the upper left quadrant have some contamination of the stomach. And that's what to do. And finish the procedure. Here, you can see. And so that's it. Okay. So to finish here, the patients start to eat on the third postoperative day. The chest tube was removed on the sixth postoperative day, and the patient was discharged on the seventh postoperative day. Here you can see the X-ray, 30 postoperative day X-ray. And for final comments, Valeria.
Thank you, Dr. Collet. Dr. Kasim, your final comments, please.
Well, there are surgeons and there are super surgeons, then there are master surgeons. And you saw the work of a master surgeon, beautifully done by him. Question, Dr. Collet, how much of that stomach did you remove? What was the dimension of the resection you did?
It's very small resection. It was 3 centimeters of the resection.
Okay.
And again, through the resection, take this out through the trochanter. For using this stapler, endoscopy, you need to use 12 centimeter trochanter. So it's more larger.
So when I see perforated stomach ulcers, they're usually pinhole, like Dr. Hoffman has mentioned. This seems like a little bit bigger than that. So it tells me that the tip of the knife, not only the tip of the knife went through the stomach, maybe a little bit more than that. So if we would have played ostrich, not do anything about this, I think the patient would have been in serious trouble. And the missed injuries always cause heartache to me, just like it would cause heartache to all my fellow surgeons there. So I always remember, when you see one thing, make sure you're not missing the other thing that caused that first injury. So the way that Dr. Collet treated this with the laparoscope is absolutely fantastic. But in my hand, I would have done this with a laparotomy. I would have done a laparotomy and then probably sutured that hole in the stomach and patch it with an omentum or something like that, then call it a day. But it's either way is acceptable as long as you don't play ostrich and leave it alone and come back for some other day to deal with it. That's when the patient becomes really sick. Very nicely done and nice, good educational case. And all in all, it is worth putting in the library to review it one more time for future. Thank you.
Thank you, Dr. Kasim. Dr. Antrak, like that?
Yes, masterful management, superb case. So based on what you found initially, an initial CT with double contrast wouldn't have shown a leak because the injured part of the stomach was incarcerated through the hole in the diaphragm. And if you had done it the other way, reduce it from the chest, suture the diaphragm and the chest, and then done a contrast study, very likely, if not on the CT and upper GI series properly done, would have shown a leak, but then you would have lost some time and had some additional leakage. So I think doing it your way, and I think laparoscopy is minimal morbidity, that was certainly ideal, and something I would keep in mind with a similar case. I think that was a good approach. Basically, it's what Dr. Frisbee said. You, instead of reducing it in the chest, you go in the belly, find the what's incarcerated through the hole in the diaphragm, and then that should show you where the pathology is. That's exactly that worked out exactly that way here. Well done.
Thank you, Dr. Antrak. Dr. Ochman, Boston.
Well, I would continue to dig deeper into my grave. I think that I respectfully disagree. I don't think that the leak stopped because the stomach was incarcerated. What you can see in the chest was omentum, not the stomach. I think the leak already stopped because the omentum sealed the leak. It was a very small hole. 3 centimeters were resected. Doesn't mean that the hole was 3 centimeters. The hole appeared to be at the most 0.5 centimeter. And and I continue to, maybe I have bad luck with radiology, but I find out that the CTs and are very unreliable to detect the small leaks after trauma. So I think is this patient, Dr. Collet, was this patient leaking when you went there, or the omentum was kind of sealing the hole?
No, they are leaking. They are leaking. The omentum is not sealing the stomach.
Okay, so I dig my grave deeper.
Thank you, Dr. Ochman. We have a question from Dr. Pereira. Dr. Pereira.
Yes, I'd like to make 2 comments. First, Dr. Collet, Francisco, congratulations on this fantastic case again. It taught us a lot, but I'd like to emphasize that we should always look for the second hole. This is something that I learned from Dr. Collet himself in one of these many cases. If you find one hole, try to look the other one, especially behind the stomach. So I'm not sure he done this because in the movie we were not able to see. I lost it. Would you open the gastrocolic ligament to see the posterior wall of the stomach, Francisco?
Yes, well, Gustavo, you can do. I don't show the whole movie because you have to handball the small ball. You can handball the column. You can see the posterior portion of the stomach, but is there too much to put in the movie? So I don't put.
Second point here is the association of the diaphragmatic injury and empyemas. We haven't seen a greater frequency of empyemas after these combined injuries, diaphragmatic together with stomach or colon injuries. So I would ask you, what would you do for decrease this infection? So when we are in the laparoscopy, you kind of open the diaphragm to wash the thorax, but you had already done the thoracoscopy. So would you wash differently because you found gastric hole together, or not? Just simple measure of draining, that's it.
Gustavo, you can, if you start with a laparoscopy, you have bowel injuries and or stomach injuries and diaphragm injuries. Sometimes you can open more the diaphragm and then wash the pleural cavity and put adequate chest tube. But in this case, you have a chest tube. So I start with a thoracoscopy. I can wash the pleural cavity and realize all the adherence of the pleura, the pulmon to the pleural cavity, and then put a chest tube. Then I go to the abdomen. So there is no more contamination or more very small contamination at this moment for the abdomen through the chest. So in this moment, I start with open close the chest, close the diaphragm, close the stomach, and wash the peritoneal cavity. So you can have, usually, if you can have MPM in these situations, of course you can have, but what you do with the first time is washing the pleural cavity and put adequate chest tube.
Okay.
It's only we can do.
So washing is an alternative here.
Yeah,
Washing.
if it's appear later, you can go or to put another chest tube or can make another vast and put another drip, but it can continue to observe the patient.
Great case. Thank you.
Thank you.
Thank you, Dr. Pereira. Dr. Frisbee, your comments, your final comments, please.
I thought it was a great case. I thought it was something that we don't see every day, and but it really sets your antenna up for just ringing away, you know, just buzzing away. So it was just a terrifically good case for us. And to my good friend, Dr. Hoyman, I wouldn't worry about heresy. None of us is Torquemada. So you're among friends. That is all I have. Thank you, Dr. Collet.
Thank you, Dr. Frisbee. Dr. Fraga, sorry.
Excellent case. Very well done, Dr. Collet. Congratulations. I have only one question for the group. If you have this injured on the right side, the same region on the right side, you need to suture the diaphragm. Do you do this by a laparoscopy, or on the right, do you think you can do the only one or two stitch like you did by thoracoscopy? Do you have experience on the right side, Dr. Collet?
I can start with, sometimes I use the right side thoracoscopy, and sometimes I go to laparoscopy. Sometimes it's very difficult to see by laparoscopy, posterior injury of the diaphragm in the right side. In the left side, you can move the spleen, you can move the other, you can see sometimes the posterior, but the right side you cannot see.
Okay, thank you.
Dr. Antrak, would you like to make a comment?
Yeah. So on the right side, though, it's not that the same degree of problem, because if anything, it would hit the liver, and if he's not bleeding into the chest or the abdomen, you know, an injury like that, do you really need to sew that up or worry about visceral injury? And I would ask that to Dr. Collet.
Yes, there is a right chest. Sometimes you don't have blending. You cannot not explore too much because the liver can tamponate the diaphragm injuries, and then it's difficult to make herniation in this site. But sometimes I have seen some injuries, some diaphragm defects that increase during the life of the patient, and sometimes maybe herniation, some abdominal continuum to the chest. So in our service, sometimes we will have injury on the transition of the right on the left side. You go to laparoscopy to see if there is a defect. Sometimes you cannot see the defects through the CT as the moment of the trauma. Sometimes it may be along the life, during the life, they increase the abdominal pressures through the pleural cavity, so can have herniation of abdominal contents to the chest. So sometimes you can see some people comes to us with a late diaphragm injuries with herniation.
Okay, thank you. Anyone else have any comments? No. Okay, thank you very much, Dr. Collet and all the panelists, and we hope to see you next week.
Okay, thank you very much to listen our presentation and share your experience with us. Thank you very much.